Hello all, my name is Nabi Azano. I am a Senior Health Information Technology Specialist at DHIS2 DHIS Partnership. I would like to thank the symposium organizers for giving this chance to present our initiatives to the symposium participants. In this presentation, I would like to share and present Ethiopian Ministry of Health's efforts and solutions on how it implements different health information exchange solutions to improve health information system data qualities, particularly focusing on DHIS2. So just to give you background information, over the past decade, Ministry of Health has been implementing various health information systems and initiatives that differs in scale and targeting health challenge. And these initiatives are implemented across the country at the national level, and some of them are at the facility or institution level. So the major digitization initiatives that are implemented at national are like DHIS2, which is a national health management, electronic health management information system, which is deployed over 25,000 health facilities. And some of them are point of service systems like AMR and electronic community health information system, which is a national implemented mobile app system for health extension workers as a job aid. And it is currently implemented in more than 7,000 health centers or health posts. In addition to that, there are developments in the area of supply chain management, health community insurance systems, and as well as developing a master facility record registry, and also a national health data dictionary system, which is developed on the open concept lab reference technology. In addition to that, there are also efforts to develop interoperation between these digital health systems using a different interoperability layer. And also there are efforts to design and develop a data warehouse which will be used as a data source for business intelligence and analytics. So even if there are promising progress in these areas, these efforts are characterized as fragmented, and there is a duplication of efforts in development, in implementation. And there is also a challenging environment to develop and provide data exchange standards, and this creates a limited environment for coordination between various stakeholders. And ultimately, this creates a lack of informed decision making at the national level, which will have an impact on data quality as well as data reporting. So in order to address this challenge, the Ministry of Health developed a framework, the Ethiopian e-health architecture framework, which helps to show how these different information systems, data sources, will exchange data and interoperate, so that it will help to achieve the Ministry Health strategic goals. So this health architecture has mainly 5 components, and a major component, which is under the shared service, will help to register commonly shared information sources like facilities, clients, health worker, as well as terminologies that will be used by various health information systems. So these shared services are one of the major components that is supported by the Ministry of Health in order to perform standard-based interoperability solution. The other component is the institution-based HIS system, which includes like DHIS2 and the health insurance systems, which are implemented at a national level. And there are also point of systems like AMR, lab systems, electronic community health information system, which collects individual or case-based information. And there is also analytics and business intelligence component and population-based data sources. So all these components are planned to exchange data through interoperability service. And this interoperability service will have different kind of features like authenticate, encrypt, and route different transactions so that it can be used for validation as well as managing different security level transactions. So the reason that we want to explain this e-health architecture at the national level is the way different health information systems exchange data should follow this guideline so that data quality and reporting will be improved. So just to give you a brief background on the DHIS2 implementation status in Ethiopia, DHIS2 is implemented in Ethiopia for different purposes, like mainly for the electronic health management information system, as well as for tracker-based implementation for COVID, COVAC vaccine tracker, and other disease tracking for other diseases, as well as managing material and regulatory management systems. In this presentation, I will focus on the electronic health management system. And this system is actually started in around 2008. And from 2008, it becomes implemented through various revisions. And in 2016, the first DHIS 2.27 version has been implemented. From that year, the DHIS2 become customized, updated, revised, and currently the 2.36 version has been implemented in 2022. And there is also a revision for HMIS indicators. Like in 2008, it's around 108. Now currently there are around 177 HMIS indicators that are implemented in DHIS2. So the current implementation of DHIS2 is at a national level across the country in 12 regional health bureaus, around 108 zonal health bureaus, and 987 waradas or district health bureaus. So there are around more than 25,000 health facilities report through DHIS2. So managing this level of information and organization units in DHIS2 is very difficult, and because the facilities have multiple informations like ownership, facility type, and additional attributes. So managing each facility's information is very difficult, and it is one of the data quality that we want to improve through using interoperability. So these facilities, new facilities might add, or some facilities might change, and waradas might be merged, or new waradas might be created. So this needs a very routine managing these facilities. So DHIS2 need to share or get this information from the master facility record. So one of the interoperability solutions that we are planning to improve the data quality of DHIS2 is through interoperable with the master facility record. In addition, DHIS2 has more than 39 data sets that are used by different district health office or facility information to report routine data. And there are a number of data elements and data sets that are managed by DHIS2. So when we discuss the ECHI, I mean the Electronic Community Information System, which is a point of service system, reports data to DHIS2, it has to be aligned with these data sets. So I will explain later how we managed the data elements and terminologies across the DHIS2 and ECHIS. So how interoperability helps to improve DHIS2 data quality? So as I said, we focused on two use cases. The first use case is on improving the health facility data or information exchange between the master facility registry, which is the main or single source of information for facility information across the country. And we also want to improve data that comes to DHIS2. Currently, these aggregate data are reported manually through DHIS2 form. And we have various implementation of point of services like MR and DHIS. And we want to get this data through the system instead of using manual intervention while reporting aggregate data to the ministry or regional level health offices. So when we develop these solutions, we follow human-centric design which has three perspectives. There is a human or a user perspective, which we want to automate so that users or those who use the system will be benefited by implementing this interoperability solution. And we also want to see the process perspective. So this interoperability solution needs to improve the process so that it has to be helpful and it has to automate and add its share for improving the data quality. And the third perspective is the technology perspective. While implementing and designing these solutions, we want to align with the Ethiopian health architecture, and also we want to follow standards as well as follow the application architecture. And those three perspectives will be the main points that we used while developing the interoperability solutions. So the first use case is exchanging health information data from the master facility record to the National Health Management Information System, which is based on DHIS2. So as I mentioned, we followed the Ethiopian health architecture principles and guidelines and standards. So the master facility registry, which is based on Happy Fire implementation, has a list of recent information data, and this data will be routinely maintained and managed by regions and different responsible directorates at the Ministry of Health. And DHIS2, which is previously the previous version of the implementation of DHIS2, maintained its own facility information, which we want to replace with the master facility registry so that it has a similar facility lists, and we want to manage this health information data outside DHIS2 so that it will be updated, and updated information will be exchanged through the interoperability service, which is implemented based on OpenHIM. And the OpenHIM system is deployed as a Ministry of Health system. So it will take data from the master facility registry and share this data with the DHIS2 system. So this trend will continue to other systems like the ECHIS system, so that most national implemented systems like ECHIS, DHIS2, and other supply chain systems will have the same facility information from the master facility registry, and this will help us to improve data analysis, data quality, and decision making at the national and regional level. So we have tested this implementation, and as you can see from the left side, we have the list of facilities in the master facility registry. And as you can see here on the left side, there is an administration unit. Under that, we have hierarchical information based on reporting and the location. So facilities has administrative hierarchies, like from region, zone, district, and facilities. And also additionally, they chose to need a hierarchical list based on reporting, which facility reports to which region or to which ward or district. So we have successfully implemented this data exchange between MFR and DHIS2. So we are moving to the production level. So this will definitely improve the data quality. So instead of creating facilities or organization units in DHIS2, it will be created on the MFR. So it will take data from MFR. So, and finally, it will have map data across the two systems. The other interoperability solutions that we developed is exchanging data between a point of service system with ECHIS to DHIS2. So ECHIS is a point of service system. As I mentioned before, it is used by health extension workers at the health post to manage their day-to-day activities and to follow their clans. And this is a mobile-based application. It's a national implementation which is based on ComCare. And the ministry is now planning to expand this implementation across different settings in the country, like agrarian, urban, and pastoral regions. So the challenge here is the health extension workers used the ECHIS systems to manage their clans or the at health post level, and data is available at the ECHIS level, at the case-based data. So while they're reporting to the DHIS2, they manually aggregate the data and report manually to the DHIS2 form. So this creates a manual intervention while reporting to the DHIS2. So if we follow the e-health architecture vision and principles, point of services systems will aggregate their data and send to the DHIS2 system directly, so without human intervention. And if we implement this kind of interoperation between this point of service system and DHIS2, it improves data quality. So here, just as I mentioned, we used five participant systems are available here. We have the point of service system, which is based on ECHIS, and the interoperability service will advise the shared services like the master facility registry and the terminology services while exchanging data from the point of service to the DHIS2 system. So this creates at least five participant systems to report monthly, quarterly, or biannually reports from the point of service system to the DHIS2 system without human intervention. So the data will flow without human intervention, and with a paperless transaction will be feasible in this kind of environment. So just to give you a highlight on this exchange, we have the interoperability layer, which asks us for example, for monthly reports, the interoperability layer gets information from the master facility record, a list of facilities that are going to report every month from DHIS to DHIS2. Then it sends data request, aggregated data request from the DHIS system, which later give this reports to the mediator to map data elements between DHIS2 and DHIS by advising the OCL. Here, the OCL is Open Concept Lab, which has a list of disease lists and terminologies, dictionaries, which are used by different health information systems. So after getting this information, the interoperability layer mediator will orchestrate and get data from DHIS and convert the data using ADX standard and sent directly to DHIS2. So this helps to exchange information data first by following standards, second by following the health architecture principles, and also participating the different shared service systems. Initially, it looks complex because we can directly send data from DHIS2 from DHIS to DHIS2, but if we when different additional participant systems comes, it might be very difficult if we did point-to-point integration. So we want to test and solve this solution by orchestrating different information from different sources. We did some mapping between DHIS, DHIS2, and MFR, and also we already did a number around 9,000 facility mappings, so that those facilities in DHIS and DHIS2 are the same with master facility record. Here, the main challenge was similar facilities might be represented by different naming or writing style. So DHIS have facility X and DHIS2 might have X1, but this has to map, and the MFR is the one which gives the decisions that this is a true or the single source of information for facilities. So we have to map these facilities before doing the interoperation. And the same thing is also done for indicators. Those data element representation in DHIS and DHIS2 are represented in a different format. So what we did was, for each program, we identified the list of indicators in DHIS2 and DHIS, and we use the Open Concept Lab platform, which is a reference implementation for terminology service, and record these data elements in the OCL system. So this data is already available, and when someone wants to exchange data, it will advise the OCL. So it will map, the OCL will map which data element is the same as and part of the DHIS2 system, and it will give the data to the interoperability layer. So as you can see here, we have a representation, family planning, repeat contraceptive acceptance for women aged 30 to 49. This is a representation in DHIS, and in DHIS2, it has a different representation. It is disaggregated into 30 to 49, but it has also two type of relationship, same as and part of. So we used this type of mapping to easily identify and advise the different health exchange between different health systems. So we did pilot tests on Oromia region in 2 zones and 3 waradas, in a total of 91 health posts. So data that comes from these 91 health posts will be aggregated and sent to the interoperability layer, and the interoperability layer will convert and adapt these reports using ADX, and finally sent to DHIS2. So using this process, without human intervention, DHIS2 will get routine aggregate data from different point of service systems. And we did this testing for the last, from September 2021 and February 2022, and compared with those that comes with human typed data. And we found that there are some discrepancies in this data that we are going to identify through this pilot site. So just to finalize our presentation, we learned that managing interoperability solution, especially at the national level, needs a very effective collaboration between different stakeholders. And even identifying and managing requirements and defining scopes to which level we are exchanging data and which standards should be very challenging things, because some participant systems are already matured, so we can't change their way of representing data or their way of the implementation. So what we did is using the interoperability layer to exchange, adapt, and orchestrate data across the systems. And there is also need to constant improving skills in implementing interoperability solution and standards. And the one thing that we learn from implementing interoperability solution with DHIS2 is the health architecture is supporting these efforts, because it's a service-oriented architecture and it helps us to guide and follow principles easily. So just to finalize my presentation, where interoperability has got a very good momentum at the ministry, and it has a management buy-in, because the Ministry of Health now advises to minimize number of digital health initiatives by removing duplication of efforts. And if we follow this and implement interoperability solution, it will also help us to improve data quality and reporting across the digital health ecosystem. And also the technology advancements of FHIR and other technologies will help us to improve this opportunity. And there is also now different shared services like the master facility registry terminal service now are getting operational, and this will help different digital health systems to share this data without managing the heavy load on their implementation. So they can easily share data from the MFR, and also partnership and sharing best practices from the global community, especially from the OpenHIE, helps us to improve our efforts in implementing interoperability solutions for improving data quality across the digital health system. Okay, thank you very much. I hope this will give you a brief introduction on our Ethiopian Ministry of Health in efforts on implementing interoperability solution with DHIS2. So if you have any additional information, you can contact us following this email address. Thank you.